values as resistant hypertension. The prevalence, as we know, the resistant hypertension approximately 13%, and more associated with elderly people, black race, and associated target organ damage like left ventricular hypertrophy and chronic kidney disease, which we have to face so many problems of hypertension, CKD, and as well as obstructive sleep apnea associated comorbid problems. So, in contrast to resistant hypertension, the hypertension is called refractory when it remains uncontrolled, even with 5 or more antihypertensive drugs, and especially including diuretics as well as mineralocorticoids also, if it is resistant, then you have to called as refractory hypertension. Then, as we know, the recent analysis of this NHNS, that is a landmark survey, the participants who are treated with hypertension, almost they are only controlled 53%, reaching the target BP. As well as they have shown the participants of especially chronic kidney disease, only 37% of control were the target pressure, and in that 25% of diabetic person also controlled. Only that means the small part are getting the target blood pressure, remaining either due to poor compliance or because of refractory hypertension, they are negatively controlled. So, I'll have to study as anti-hypertensive lipid lowering to prevent the heart attack. Unfortunately, at the 5 years follow-up, 27% are getting only 3 or more medications. This is most important. In the surveys also, it was shown that the resistant hypertension is prevalent. Either it can be pseudo because of inadequate use, true in spite of maximum medication. And etiology, if you can, these are the various causes. Whenever after 3 antihypertensive drugs, if you find a high BP of more than 130/80, it can be a suboptimal therapy or extracellular volume expansion, poor compliance with medical or dietary following, and secondary hypertension or office white coat hyper effects or pseudo hypertension, or ingestion of substances which can elevate the blood pressure, that NSAID and steroids sometimes. Side effects of any antihypertensive drugs, they may suddenly stop without the knowledge of the treating physician. Okay, then how it is screened? Once you diagnose a new onset or uncontrolled hypertension in adults, then whether it can be abrupt onset or drug-resistant hypertension, or onset of hypertension, young hypertension, that means secondary causes you have to see, or exaggeration of previously controlled hypertension, or disproportionate target organ damage, or exaggerated phase of hypertension, or onset of diastolic hypertension in elderly people, or unprovoked or excessive hypokalemia, sometimes association. All these you have to screen whenever secondary hypertension you have to suspect. Then once you screen for secondary hypertension, once you know the cause, you have to treat the appropriate cause. It is a class 2B indication, or referral if necessary to the cardiologist. Suppose if screening is undicated for secondary hypertension, we can go ahead to the true secondary hypertension not related to secondary cause. So what are the secondary causes we should know? In our day-to-day practice, the most difficult hypertension control in our practice is a chronic kidney disease, especially renal parenchymal disease. Very, very important. So many times I have to discuss with a nephrologist for the changing of the antihypertensive drugs or addition or deletion of antihypertensive drugs. Apart from these renovascular disease, as we know, we are seeing so many secondary resistant cases, and we are treated by means of renal angioplasty also, and primary aldosteronism. And this another important cause is obstructive sleep apnea. These two are the commonest causes I have seen: OSA and the renal parenchymal disease and the renal vascular disease. And of course, drug and alcohol use also very important, especially unless you history, you can't treat secondary hypertension. In spite of increasing all the drugs, you may get side effects rather than control, especially in alcohol or drug-induced hypertension. Of course, uncommon cause also you should know, that is a pheochromo, Cushing's hyperthyroidism, and coarctation of hyperparathyroidism, congenital hyperplasia, other mineralocorticoid excessive syndromes, along with acromegaly, you should think of. And most important drugs you should know in day-to-day practice as a practitioner, you should use, which will produce resistant hypertension, NSAID, contraceptive and sympathomimetic drugs, cyclosporine, tacrolimus, erythropoietin, VEGF inhibitors, alcohol, cocaine, and sympathomimetic amphetamines, and antidepressants and steroids. These are all induce salt and water retention and sympathomimetic activity, which produce a refractory or resistant hypertension. And these are the pathophysiological mechanisms involved in the genesis of the drug-induced hypertension. Ultimately, through means of these prostaglandin inhibition as well as oxidative stress, and ultimately the end result is sympathetic RAS activation, sympathetic activation, saltwater retention, which produce a sustained high blood pressure, which is drug induced. And then sympathetic oxidant. This is another important untapped aspect of the hypertension, especially Indian population. If you carefully analyze between the Indian and Western countries, the Western countries, they involved in the guidelines beta blockers as the non-guideline directed medical management drugs. That means unless comorbidity like coronary disease failure is there with hypertension, they won't prescribe beta blocker. Unlike Indian population, where sympathetic overactivity plays a major role, central part in the initiation and sustenance of the hypertension. Because the recently some survey also done, inter-heart study, where they have shown that the ABPM demonstrated the not only morning surges, evening surge of hypertension because of sympathetic overactivity in Indian population, where beta blockers play a role as well as sympathetic blockers are a key role in hypertension management. Then the link between the hypertension sympathetic overactivity, we have seen so many animal models. Human also plasma norepinephrine are very high, especially in hypertensive patients, significantly high, which is statistically significant. And they are seen both in early phases of induction as well as the sustenance of the hypertension, some of the patients. And sympathetic activity very high in young population, especially recently because of time and target oriented professions like IT industry, as well as the some other executive jobs. Young persons, we are seeing the hypertension because of sympathetic overactivity. Very, very important initiation as well as sustenance of the hypertension, especially in young population, in Indian population. And of course, as we know, obesity, as the BMI is increasing and sympathetic discharge will be more, as well as associated OSA, they have a hypoxemic stress, which will cause sympathetic overactivation, and that will produce one of the important cause of the sustained resistant and refractory hypertension. And most important, as we know, the link between insulin resistance and diabetes and sympathetic overactivation, especially in obese people, we have seen especially in type 2 diabetes mellitus. And of course, along with the cardiac autonomic dysfunction in 30 to 50% of diabetes and 40% obese, even without diabetes, also the sympathetic overactivity is the important mechanism of the hypertension. Of course, the other important activity, sympathetic overactivity, seen renal damage, especially chronic kidney diseases, as well as left ventricular failure. As we know, in the congestive failure, sympathetic overactivity along with RAS activation plays a major role in hypertension and hypertensive heart failures. And these are the algorithm during evaluation of the resistant hypertension. The most important, first you have to confirm the treatment resistance, especially the clinic BP more than 130/80, patient taking more than 3 or more antihypertensive drugs, especially taking AC inhibitors or ARAPs along with calcium channel blockers and diuretics. Even the maximum tolerated doses also, if they control, it is a pseudo resistance. If it is which you can confirm by means of ambulatory BP, and if ambulatory BP is or home BP showing consistent high levels in spite of, then you confirm. Then you rule out the secondary causes, like as I already mentioned, renal causes, endocrine causes, and obstructive sleep apnea and coarctation syndromes. Once you assess the target, this is the algorithmic evaluation of the hypertension, especially resistant refractory, and you assess the target organ damage, especially the retinopathy, left ventricular hypertrophy, and atherosclerotic coronary artery disease, and renal, especially albuminuria and EGFR, you have to evaluate, and peripheral artery disease, especially ankylosing index. This is a comprehensive evaluation, especially during the evaluation of the resistant and refractory hypertension. Once you diagnose, what is the treatment strategy? Most important is autonomic dysfunction, especially sympathetic overactivity, plays a major role, especially in metabolic syndrome. Also, the treatment of patient with hypertension should take account into metabolic syndrome also. That means insulin resistance and diabetes or impaired glucose tolerance and obesity. All these you have to treat along with the sympathetic overactivity. So in the step one, you have to maximize the lifestyle modification along with the treatment of the secondary causes. and optimize the use of three-drug regimen of inhibitors, ARBs, and calcium channel blockers and diuretics. Suppose if BP still reached the um, mm, not adequate levels, then you have to use the either indapamide or chlorothalidone as step 2 treatment. With this, definitely the blood pressure is under control. So still it is not achieving the target BP, then you have to go to the step 3, that is mineralocorticoid receptor antagonist like spinolac, loplenan. Then definitely the BP will be controlled. Sometimes if hyperkalemia is one of the problems with the adding of mineralocorticoids or not reaching the target levels, then you go to step 4, that is the heart rate, that is alpha blockers or beta blockers like metoprolol or labetalol you have to use. Then definitely BP under control. Then still it is not under control, then direct vasodilators, especially the hydralazine, 25 milligrams 3 times a day, and you can reach the maximum dose, especially comorbid problems like heart failure with a dissatisfaction you can give. But still BP is not under control. Then as a last resort, the most important is central sympatholytic drug, minoxidil, either 2.5 milligrams 3 times a day for hydralazine, then under control. Then you have to add on to the minoxidil you have to use. So most important, these are the steps in the management of the resistant hypertension. Then the therapeutic objectives, the most important is you reduce the sympathetic overactivity. You should be the primary goal in non-pharmacological management as well as pharmacotherapeutic strategies, especially the hypertension is not under control. So for this, the most important drugs, that is the drugs which will control the sympathetic outflow, that is as we know, the vasomotor center is situated vasomotor in the medulla, that is called rostral portion of the ventrolateral medulla, which is the key vasomotor center, which is under sympathetic control. Of course, this is governed by means of hypothalamus in the brainstem, that is medulla, that is RVLM nucleus. That is the ultimate common pathway for a descending sympathetic stimuli, especially during stress period hypotension exercise, and that will maintain the vasomotor tone, acting at the precapillary arterioles. Then the target of blocking the sympathetic outflow at your RVLM level, the central sympathetic blockade selective agents will come, especially stimulation of alpha-2 receptors and I1 receptors, which are selectively located in RVLM nucleus, which reduces sympathetic outflow. And these are the drugs classification, the central sympatholytic drugs, which will effectively reduce the sympathetic flow so that it will control the blood pressure. The preferential alpha-2 agonists, as we know, the clonidine, guanfacine, and methyl dopa, and second generation, more advanced, the central sympatholytic, the I2 agonist, it is a more preferential one, that is moxonidine and dilaminidine. So the alpha receptor stimulation, which will have some associated side effect like sedation, especially the first generation central sympatholytics, which reduces central sympathetic flow by stimulating alpha receptors in RVLM center, rostral ventrolateral medullary center, that is vasomotor center of the medulla. They also stimulate alpha-2 receptors at the locus coeruleus, which can produce sedation. The undesirable side effects like dizziness and lightheadedness, drowsiness, dry mouth, constipation also occur, along with the rebound hypertension, which is very severe sometimes. So the more selective receptor, that is imidazoline receptor and agonists, they came into this one, more selective receptor, which will reduce central sympathetic outflow, and especially these moxonidil, that is our present topic, which without sedation, it will control the, reduce the sympathetic outflow and control the resistant refractory hypertension. If you take the pharmacokinetic characters and efficacy of the moxonidil, almost it has 200-fold more selective activity on I1 receptor than alpha-2 receptors, unlike clonidine, which is a non-selective agonist. And moxonidil preferentially stimulate the I1 receptors in RVLM nucleus of the medulla, which is the vasomotor center, decreases sympathetic tone, central sympathetic tone, causing a decrease in systemic vascular resistance. That means once vasomotor tone in the vessels will be reduced, sympathetic systemic vascular resistance will be reduced, so that the blood pressure will be under control. Then these are the facts. As we know, The end-stage renal disease have high-end sympathetic nervous activity and a role in hypertension, especially monotherapy compared to other antihypertensive combination therapy you have to use, and especially obese, elderly, uncontrolled hypertension. And not only that one, it has a lot of pleiotropic benefits is also there. And as a monotherapy, meldazine and controlled as a 8-week trials, the trials which have shown the monotherapy which will produce significant reduction of the systolic as well as diastolic pressure at the average of 15 by 10 millimeters of mercury compared to the placebo. And then in case of end-stage renal disease, compared to the placebo, if you can see, there is a significant reduction of the sympathetic activity as well as the systemic vascular resistance and heart rate also, both systolic and diastolic blood pressure. Compared to the placebo, the moxidine has a efficacy, and those especially acute effects in patient with sympathetic nervous activity and hemodynamic measurements in case of end-stage renal disease. So these are the graphical presentation how minoxidil reduce the sympathetic nervous activity bus, as well as consequently the reduction of the blood pressure with up to 6 months of treatment, sustained treatment with minoxidil, how to reduce the sympathetic nerve impulses and vasomotor tone impulses to the vessels. Its conclusion, end-stage renal disease, the low dose of moxidil produce sustained and substantial reduction of the sympathetic outflow without hemodynamic compromise them. I've seen so many times. Actually, I want to ask Dr. Sunda, and also at the end of this lecture, especially the most difficult subset of hypertension is end-stage renal disease. In 3 drugs, 4 drugs, 5 drugs also, still blood pressure is 180 by 180 by 10, which is a significant risk factor. Ultimately, these patients develop the cerebral hemorrhages and strokes because of the high-end blood pressure, where this drugs plays a significant role without affecting the serum creatinine as well as kidney side effects, undesirable side effects. It will control the hypertension more effectively. Then coming to the how is the effect on the renal function? No serious adverse effects on various that levels, especially glomerular filtration rate, and no aggravation of impaired renal function, unlike a colundin, where the rebound hypertension is more and more. And significant BP reduction is also observed in patients with a severe renal insufficiency, that means EGFR less than 30 ml per minute. And if you take the moxidil in eprosartan treated chronic renal failure patients, this is a study where it was shown the addition of moxidil to eprosartan further reduced the mean arterial pressure of 9 millimeters mercury, as well as the sympathetic nervous activity of 7 bursts per minute almost. So that means significant reduction of central sympathetic outflow impulses. It reduces the blood pressure also more effectively. And not only that one, it reduces the microalbuminuria by 24% almost. So the conclusion, as an add-on therapy to the ARBs, especially in chronic renal failure, this moxidil plays a significant role. Then in chronic renal failure, addition further reduced by 9% and reduce not only the reduction of the absolute values, it is translated in terms of the kidney protection. That means a reduction of the microalbuminuria as an additional finding, which we have shown in this study. So efficacy of this safety of moxidil in patient with a metabolic syndrome, this OBGTA trial, which was shown, which is a non-intermittent observational clinical study to evaluate the treatment of moxidil to assess the changes in metabolic syndrome, especially the parameters. If you say this almost 748 patients of sample size over 18 years of age with a metabolic syndrome and poorly controlled hypertension, if you take over 6 months design of the study, the majority of the patients, they completed the study without any side effect during the study, and mostly prescribed moxidil to add-on treatment, especially these metabolic obese people have refractory hypertension. Almost to add on 81% add-on treatment they received, and lack of efficacy of the combination drugs, that means 3-4 drugs. The most frequent dose which effectively control the blood pressure is 0.4 milligrams a day as a monotherapy. Also, it is useful not only as an add-on drug. And another important observation, in treatment was 19.2% of patients following a first visit, almost 7.7 patients during the last study visit. So all parameters, if you take the blood pressure, body weight, waist circumference, lipid profile parameters, and the glycemic profiles, they are significantly improved in this study. So conclusion, over a period of 6 months of this follow period, highly significant change observed, especially in the lab parameters. In addition of the moxonidine in existing treatment, not only reduction of blood pressure observed, but also highly significant changes in metabolic parameters without any significant modification the treatment. So the treatment should be considered as metabolically neutral with added value of positive effect on the metabolic parameters, especially in hypertension in metabolic syndrome. And then improvement of hypertension control with the emerging agonist moxidine, that is a multinational metabolic syndrome populations of this study collected the data in a minimum of 3 consecutive patients with uncontrolled essential hypertension for metabolic syndrome eligible to receive moxonidine, that is 0.2 to 0.4 mg once a day for 6 months, either therapy or adjunct therapy to the current hypertensive drug. And so this is the graphical representation as a monotherapy as well as a combination therapy, how it produces the effective reduction of the blood pressure, which is statistically significant. Very, very important. This is both systolic blood pressure by the type of antihypertensive drugs. This is a cohort as we show, add-on therapy as a monotherapy. Definitely significant reduction of the systolic BP was observed. The trends of the laboratory parameters also, if you observe in the syndrome, they are expressed, they are indicated, and it is metabolically neutral as you observed in the situation. So the summary of suspected adverse drug reaction, if you carefully see, they are very, very, very meager, 0.1 to 2.2%. So conclusion of this study in metabolic syndrome, the moxonidine therapy reduces the blood pressure very effectively and to the satisfactory levels. And there are trend towards the improvement of the metabolic parameters, not only neutral, it is tend to improvement. So the overall effect of moxonidine treatment is consistent. Reduction of total cardiovascular risk also, along with the absolute control of the hypertensive values. So this is ultimately in this study also, it was shown that the data, the criteria of metabolic, especially the 0.2, 0.4 mg, the monotherapy as well as combination therapy, it is showing more effective management as well as reduction of the cardiovascular risk factors. And another important, especially obese, non-controlled hypertension, nowadays we are seeing so many patients in our day-to-day practice where extremely difficult in obese patients, the blood pressure control. This is a multi-center observation study. It was shown in Madrid for a period of 6 months. Was shown marked reduction of the blood pressure to 23/12.9 systolic and diastolic over a period of 6 months was then, along with improvement of insulin resistance and significant reduction of the creatinine clearance. So the conclusion is a very useful and safe, metabolically neutral, sometimes metabolically positive also. It will give favorable effects in controlling the hypertension in obese people. And of course, this is the graphical representation where the moxonidine control both the systolic and diastolic by 23/13 in obese hypertensive patients. And not only this one, it also has suppression of obesity is related to hypertension by inhibiting the sympathetic nervous system flow from the brain and counters in the primary pathophysiology of hypertension obese. So inhibition of sympathetic outflow to skeletal muscle blood vessels not only the control the blood pressure, also improve the insulin sensitivity. That's why it produces the metabolic improvement of the glycemic parameters and lipid parameters. Then coming to the elderly, most important as add-on treatment, elderly refractory or resistant hypertension is the most important objective in this study, where the significant BP reduction of 15.4 by 7.4 observed. Not only that, 24-hour BP control also observed in this study. So moxonidine can be given as add-on treatment in elderly patients whose hypertension is poorly controlled. So with the 2 or 3 antihypertensive drugs. So this is also some of the subsets we observe day-to-day practice. Elderly patients with a refractory hypertension, where it is useful as an add-on treatment. Then, so elderly resistant hypertension is a graphical representation where not only it reduces the absolute values, but also it will control both diurnal as well as nocturnal hypertension as add-on treatment to the three drugs, moxonidine, very useful, effectively controlling the blood pressure to the target levels. And coming to the topic study, which is a moxonidine combination and treating the essential hypertension. It is almost 566 at 138 centers in UK over 12 weeks. Those who are not responded to the earlier medication, almost 52% have shown reduction of the blood pressure by 17 by 13 to the moxidine monotherapy. So non-responders, 48% with amlodipine, they offered great response, that is moxidine, actually 46.9% of achieving the goal blood pressure. So this is a very, very important as a therapy, monotherapy, or in combination with amlodipine. As we know, amlodipine is a very effective antihypertensive drug. So if the amlodipine non-responders, this drug is very, very useful in amlodipine non-responder hypertension to achieve the target blood pressure. So this is the topic study where non-responders responders after giving the add-on to moxidipine to the amlodipine, so that 47% patient achieved the target blood pressure. Then compared to other antihypertensives, how is the efficacy, especially if it was enlapril. This is a study where it was compared with enlapril. So the moxidine reduction of the compared to enlapril almost very effectively 16 by 10 meters mercury more compared to enlapril and superior to the placebo. So it is very effective tolerant antihypertensive as good as other agents like enlapril with the trough and peak ratios. That means smooth control without any fluctuations, most important. Sometimes enlapril, there is no control of the blood pressure, target BP not achieved, and definitely this is very, very useful. Then compared to other antihypertensives like enlapril, this is the graphical representation where 5 milligrams enlapril will compare to moxidine 0.2 milligrams. How the absolute values of hypertension is systolic and diastolic lower compared to the enlapril. And coming to the other antihypertensive, that is first calcium channel 20 mg, this was shown very effective, well tolerated, and without side effects seen in nifedipine. Almost 70.87% those are nifedipine not controlled. The BP will achieve with moxidipine. So this is the graphical representation how it is efficacious compared to nifedipine. So then coming to nitendipine, also it is more efficacious, especially new end-stage renal disease cases. Almost 81% cases it is as high as effective control and increase the life years lived by their patients, and statistical calculation is 0.044. And this is compared to other antihypertensives, 81% reduction, that is nitendipine, end-stage renal disease. This moxidipine, how it is very effective and control of the hypertension. Coming to clonidine, compared to other central sympatholytic drugs with clonidine, if you can compare the efficacy, first generation clonidine, the withdrawal of moxidipine, BP rises gradually to base level in 3 days. In a sudden spurt of BP seen in clonidine. That is most important advantage of central sympatholytic moxidipine compared to the clonidine, where the rebound hypertension and hypertensive crisis we will see. Whereas moxidipine very safe and no hypertension because of its active imidazoline receptor. And the crossover compared to moxidipine, see a double-digit reduction is seen without any rebound, and crossover of clonidine to the moxidipine. And moxidipine compared to eprosartan, that is the ARBs, angiotensin blockers. Moxidipine controls sympathetic activity caused by both angiotensin mediated and angiotensin independent mechanisms. Very effective compared to ARBs. It reduces the sympathetic overflow as well as arterial blood pressure, and more effectively with two digits reduction. And coming to this a landmark camera study which was studied post-mortem surveillance, total of 4,005 patients at 772 practices in Germany. It was shown marked reduction of blood pressure. That means most effective blood pressure control, and not only through decrease of sympathetic vasomotor tone, most important, 23.9 by 13.2 observed, and especially where BP is very high in severe diseases. So moxidipine effectively reduces the BP in patients with a metabolic syndrome while simultaneously reducing the body weight in obese patients. There's a landmark camera study which was created, and these are the graphical representation, and where the reduction of the blood pressure is very, very, very significant. 95% of the responded both diastolic blood pressure as well as systolic blood pressure significantly. And coming to 7 years clinical experience of moxidipine, it was shown that there is a tolerability compared to other sympatholytic drugs. especially 20 phase 1 trials, the adverse effects, especially somnolence and dizziness, which is a dose dependent, are less frequent with the dose of less than 0.6 milligrams. On 30 trials in 15 years, it was shown with placebo, no serious related adverse event, and clonidine and least withdrawal rates. As you, once the patient has no side effects, effective control, not automatically it won't be withdrawn by means of practice physicians. The PMS study where 19,000 patients had the side effects are as low as 5 to 7%. Important is another important metabolic syndrome where endothelial dysfunction is observed, and especially these all the parameters of Moxovas with the diet alone, which is showing this endothelial correction dysfunctions improved and halts of progression of cardiovascular diseases by reducing or controlling the blood pressure very effectively. And coming to the pleiotropic effects are also observed with the moxanidine, especially compared to the metformin multi-centers in over 11 centers in Russia, in statistically and significantly reduce the AUC for insulin by 12%, whereas metformin increased the same by 0.3. So these are the subtle cold parameters where it will improve the metabolic parameters by means of its pleiotropic effects also. Coming to the insulin resistant, there is improved the insulin sensitivity by 11% by reduced sympathetic flow to the muscle blood vessels. And obese hypertension, almost 45.6% of insulin levels, 23% reduction of the fasting insulin levels, and 70% reduction of the plasma leptin levels, where it was seen in obese metabolic syndrome patients. So metabolic also there is improvement by means of its pleiotropic effects. So there are Indian trials also, there is specially conducted Indore, Mumbai, where it is open randomized compared to clinical, and safety of moxidipine versus ramipel versus losartan, it was shown almost 16.57% decrease in systolic blood pressure with the moxidipine group treated with compared to the ramipel, and this one where 10.5% and 10.4% were observed. And the conclusion, as a monotherapy also it is very safe and effective and more efficient compared to ramipel. These are the Indian trials which was shown with the other competitive drugs, more effective reduction of the standing blood diastolic as well as systolic blood pressure. And coming to pharmacokinetics, that absorption from 90% to 89%, food doesn't affect blood-brain barrier, only 7% bound to plasma proteins, and 10% when administered dose is metabolized, 90% will exceed to the urine within 24 hours. So the half-life is 1.8 hours. So it increases, especially in the renal insufficiency. Peak plasma reached by 30 to 180 minutes. So maximum antihypertensive efficacy is observed in 2 to 4 hours, reached the peak, and it persists up to several hours after the drug disappears from blood. So these are the indicated either mild to moderate essential hypertension, and most important resistant hypertension with end-stage renal disease, chronic kidney disease, that is, and diabetes, and obesity-related metabolic syndrome, as well as obstetric sleep apnea syndromes. These are the starting dose 0.2 to 0.3, increase rate to 3 weeks interval to 0.6 milligrams, and divided doses you can give as a BD dose. Single dose should not exceed 0.4, and of course contraindication, as you know, pregnancy, lactation. And in elderly people, approximately it was AUC was increased by 50%. So lower doses should be very, very important. And renal failure also mild to moderate, yes, you can give single dose not exceeding 0.2 mg, routine 0.4, the kidney mild to moderate 0.2 should not exceed it, and no more than 0.4 mg should be given. So children, of course, not to use below 15 years. Of course, severe renal insufficiency less than 30 ml, there is important, it will affect the pharmacokinetics. So 24-hour patient, very small study was done where 0.3 mg was well tolerated with a severe kidney insufficiency that can be addressed by Dr. Surya. The trial concluded that the patient with renal failure it should be individualizedly titrated depending upon the clinical response. And these are the precautions. Beta should be stopped first, and then moxidipine, because a double sympatholytic and it will cause vasoparalysis, and use with caution, especially with angiogenetic edema and severe chronic disease, unstable angina. And moderate impairment, single dose should not exceed 0.2 mg. You should be keep in mind. And then these are the advantages. The antihypertensive is comparable to that of other classes. It improves the metabolic parameters also in obese patients and obese diabetics. and impaired glucose tolerance and metabolic syndrome patients. And at least antihypertensive effect lasts for at least 24 hours. It can be admitted that is a once a day convenient dose, and it is safe, well tolerated, and has a less potential for drug interaction. Very safe and effective in add-on treatment combination therapy also. So these are the drug which is available as a commercial, that is Moxovas 0.2 mg, 0.3 mg. So most important, this is which you have to the drug. In my day-to-day practice, what I observed is most important is refractory hypertension definitely display a very significant role that I observed, especially end stage in diabetes, obstructive sleep apnea, obese type 2 diabetics, very important. And practical point, what I observed is amlodipine blood pressure did not achieve the target level. Definitely, as another add therapy, this oxytocin is very useful. Thank you.
Thank you, sir, for the wonderful session. I'm sure with the evidence that you shared, along with the vast experience, the listeners would definitely help the listeners in managing patients with resistant hypertension and have better patient outcomes. Uh, I see a few questions in the box. The first and foremost, I would request Dr. Surya Narayana to be, unmute
Experience.
himself and
Yes.
be a part of the session as well. Sir, a
Yeah,
question to you, sir, from the nephropathy point of view, sir.
yeah.
Uh, Being a centrally acting antihypertensive, moxonidine reduces sympathetic outflow, is what mentions. But
Yes.
is anxiety related as a sign for use of moxonidine as well? Have you seen some patients with higher anxiety have benefited more with moxonidine? Your opinion, sir.
No. It's anxiety I have not seen in any patients. Most patients have tolerated well in comparison to this clonidine, because clonidine will have side effects of dry mouth, constipation, but moxidine will not have. So in comparison to clonidine, this is a safe drug. I have not noticed any anxiety in any of our ESRD patients.
Wonderful, sir. Dr. Kapardhi, a question for you, sir. What is your experience in using moxonidine early in the therapy of controlling blood pressure?
Okay. Actually, to be frank, I have some reservations. Most important is I follow the guidelines. So as for guidelines, the first drugs are ACE inhibitors or ARAPs for younger population, or if they are very anxious 2 young population with high-end sympathetic activity, hypertension, beta blockers, especially Indian population, very important, which was not given. And in elderly people, I start calcium channel blockers. Suppose if they are not responding, not reaching the target BP, definitely I will rule out secondary cause. Then moxidipine I will use as a second line drug once it was not under control. And this is regarding the management of the hypertension in the early stages.
Sure, sir. Thank you for that. So, lastly, I would individually go first with Surinarana sir and then to you, sir, at Kapati, sir. The first one, the question being your approach for a patient who has reached you with uncontrolled blood pressure with three optimally used class of drugs. Dr. Narayana, sir.
Yeah. Then I will definitely add this moxonidine, and I will see the response. Simultaneously, I will exclude as Doctor just now he has elaborated. Secondary cause will rule out, and compliance, side effect, all these things has to be checked. If all these things are there and there is no secondary cause, then we'll go ahead with moxonidine and other drugs.
Sure, sir. You, sir, Kapadi, sir.
Yeah. Actually, the same thing. Actually, what I have seen, the best combination I observed for the hypertension control is amlodipine and volmisartan and hydrochlorothiazide bar clothiazide. So with these, actual majority of the hypertension will be under control. But I have seen the end-stage renal disease, number one, and number two, severely obese metabolic syndrome patient. These two groups are the patients where this won't respond with these three drugs, in my experience. Once I observed this one, along with the treatment of the primary cause, like a CPAP treatment, suppose in obstructive sleep apnea, And of course, in the interstitial disease, along with the primary management by nephrologist, add on this moxidipine I will do, so that the blood pressure will be definitely under control. As we have discussed, resistant whatever thing refractory hypertension management as per the guidelines, but definitely with the moxidipine, that refractory resistant phase will come down and blood pressure will be under control. The only thing I have no experience, maybe it may play a significant role, I do not know. Suppose young population, highly strong, highly conscious population, time target IT professionals, where the high-end sympathetic tone will be there, where we use usually the beta blockers like propranolol, or these metoprolol, all these things we use. I think that is maybe an innovative thought after seeing all these things, literature, digging out the literature. Maybe that along with the lifestyle modification like meditation, which is the best relaxation technique, I think this moxidipine is free of side effects. Maybe a role theoretically, unless I use practically. You asked one question previously. What is the role of this one in essential hypertension, in the moderate hypertension? I think these are the subgroups. Maybe this may role if I see in my day-to-day practice. I will start.
Lovely, sir.
Because
Yeah.
sympathetic flow is the main reason. Central sympathetic flow to the vessels is the main cause in those patients who are highly strung. So once I control the vasomotor tone by means of central sympatholytic with the optimal dose, without any side effects, without any rebound phenomenon, definitely till the relaxation techniques work, I will use this done rather than beta blockers, which may produce some impotence and all these, as we know, beta blockers.
True, sir.
One thing which I would like to highlight,
Yes.
in our dialysis patients, most of the patients will be fluid overloaded. So if BP is poorly controlled, then you have to remove fluid by doing ultrafiltration during dialysis. So unless until fluid is removed, BP will be uncontrolled. So this is a major part in our dialysis patients.
Yes. That's why I told end-stage disease with refractory hypertension, along with the nephrologist role of dialysis,
Yeah.
negative balance,
Yeah.
then this only works. Otherwise, just if you increase the drug side effects without any one, like OSA also, unless you reduce the hypoxemic spells by means of CPAP treatment, just add-on drugs won't treat the hypertension. That's the most important. That understanding mechanism is most important.
That's true, sir. Understanding and then accordingly managing the patient accordingly.
Yes.
True. Great, sir. I thank each one of you, sir, for a wonderful and enlightening session on resistant hypertension. I'm sure the listeners would have gained deep insights in managing a patient better using the learnings from your session. So we at Macleods would like to honor your vast experience and your kind heart to share the same on such a platform for a benefit of all current and future listeners. I, Dr. Sanket Nivale, representing medical team at Macleod Pharmaceuticals, on behalf of the marketing and sales team, I would like to thank you for supporting us in this scientific endeavor. And have a great day ahead, sir. Thank you, sir.
Thank you. Thank you.
Thank you. Thank you.
Good evening, sir.
Good evening.
Thank you, all of you. So I'm ending the meeting now.
Sure. Thank you.
Thank you.